There we go. So when we had stopped last time, we had been kind of toward the end of talking about allergies and what happens to cause them and what are the major chemicals that go throughout our body and signal these different inflammatory responses that then cause us the allergy symptoms. And when people have allergies, the damage to their body is coming from the immune response and not the actual allergen itself. It's our response to it. It's the overreaction that is damaging. And when we test people for allergies, let me go forward to this. How many of you have had this done, like on your back? Did you get a picture of it like this later, or just the list? Yeah. So what's happening during that is kind of poking a little bit of the allergen under someone's skin and see, do you get an inflammatory response? And depending on how big it swells up, they will classify that as a moderate reaction to dust, severe reaction to pyrethrum. This is a pesticide. This person reacts to most of the things. You're looking for the inflammatory response and the swelling and the edema and the redness and so on. Other examples of allergic reactions you can sometimes see through a person's skin. The point of these pictures is not for you to recognize on a person's skin what a type 1 hypersensitivity looks like, but just some examples. This one is a drug reaction. So the person, can't tell who this is, the person ingested a drug and it went all throughout their system and they're allergic to it and they are breaking out all over their body. So this could have been a penicillin allergic reaction. Poor baby. Love it when they're at that age, they do this spit bubble thing. The baby is probably having an allergic reaction to lotion or whatever they're washing him or her with, and they're having skin inflammation at the place where the lotion or the Johnson's baby wash is touching them. One of our boys had that. So you can sometimes see allergic reaction through the skin, but not always. These are some examples how that might look. This is a good review of what's happening during allergies, and what are the different steps that it takes to start this. So you have to come in contact with the allergen. And you have to have plasma cells making specific antibodies against it. And those antibodies are going to prime or activate these mast cells to have them on their surface, so that then when you encounter the antibody, they're going to release the chemicals. And then that causes the side effects of the allergy. If you've got these pictures right onto this would be the first exposure. First time you're ever exposed. This is during the secondary exposures or any other time that you're exposed to it, then you're going to react to it. This row is kind of saying, how can you help allergies get better? There's different strategies for this. One of them is, kind of obvious, just try not to get around that thing. Try not to be exposed to it. Avoid it if you can. If you can't avoid it, you could take steroid drugs that are going to affect the ability of your immune system to respond to it. Those are going to suppress all different types of immune responses. This one we don't so much use for allergies because it's really expensive. But we could give you antibodies against antibodies, like antibodies to destroy your own allergic antibodies. Or we can give people drugs to prevent mast cells from releasing the chemicals. But this is what we tend to do the most because this is the cheapest. So just give people drugs to counteract the individual chemical effects, like an antihistamine. That one I want to use as an example of why you feel the way that you do when you take an antihistamine. Maybe some of you are taking them right now for your allergies. So if we take drugs that are classified as antihistamine, those are supposed to be counteracting the signaling of histamine. So I'm going to go back a couple of slides here and think about what histamine usually does. So if we're releasing histamine, it's because our mast cells have encountered the specific allergen that we've become sensitized to, and then they're releasing inflammatory chemicals into the blood, which might include histamine. What histamine does is to increase inflammation and increase secretions in that particular area of your body. So if you take an antihistamine, it's going to do the opposite effect. So you will decrease inflammation, including the redness and the swelling, and so on. And it will decrease secretions all over your body. So if you're allergic to pollen, and when the pollen gets bad, you take antihistamine drugs, and they work to do that. But if you feel like you're dry as a desert, up here. That's because they're decreasing secretions, and you're not making as much mucus, and you're not making as much tear production, and you're literally dried out. That's why. That's what they're doing. They're counteracting inflammation. My dad takes a lot of antihistamines because he's allergic to some unknown stuff. He needs to go and have this done. And he and my mom like to sing in a choir. And his antihistamines are making his throat so scratchy and dry that he can't sing well. So he kind of tries to balance, like figure out how many days ahead to not take the antihistamine so he can go and sing in the choir for the hour and a half a week, trying to balance out those effects. So that's a lot of information about allergies, and allergies are an example of type 1 hypersensitivity. We're going to spend the rest of the time today, I think, talking about types 2 through 4. But before that, let's kind of look back at what are the characteristics of type 1. So type 1 includes allergies. A true allergy is going to show up immediately as soon as you're exposed to the allergen. There's not a time gap. So that's a big part of what makes something class 1, type 1, instead of types 2 through 4. These are involving specifically immunoglobulin E. That particular type of antibody. And mast cells. So we've got mast cells involved, and then we've got those allergic mediators. Those are the cytokines, those chemicals that float through the body. And then here's a few examples of those. Remember that anaphylaxis is the real extreme, life-threatening type of allergic response. So those are the characteristics of allergies, and those are the most common out of all of these hypersensitivities. These other three, we're going to know some info about them, but not in the level of type 1. Is anybody not allergic to anything so far? You are so, oh good. I hope you never become allergic. I wasn't allergic to anything until I was about 20. And then it was cats and pollen, and I've managed to stay like just cats and pollen. It's too bad because I like cats. For me, if I wasn't allergic to them. Yeah, that was, I wanted to make sure I said everything about allergies that I wanted to. Okay, so next we're going to look at type 2 hypersensitivities. And these, remember, these are listed by Roman numerals. So type 2 written like this. And these particular types of hypersensitivity responses are characterized by formation of what we call immune complexes. Where you've got antibodies complexing with something, or agglutinating, let's say, in the blood. So the most common example of this occurs during pregnancy, if it's pregnancy with your second child in a certain situation. To understand this, it kind of goes back to when we talked about blood groups and blood types in AMP2. I'm not going to so much go over that, but moms and babies can have different blood types. You don't always have a child with your same exact blood type. So if you have a first pregnancy and your baby has an antigen that you don't have as the mom, your body is in some ways treating the babies like, oh, this is a foreign object. It's kind of a foreign object, it's half you, but in that first pregnancy, you're experiencing this half foreign object, and you will create an immune response against it for future babies. So first pregnancy is fine. It doesn't matter what the baby's blood type is or your blood type is. It's going to be fine. But if the mom herself is a negative blood type, mom is, like A negative or B negative or AB negative. So if the mom is a negative blood type, and baby one is a positive blood type, subsequent, so any pregnancies after that, pregnancies where the fetus is a positive blood type after the first one, if the mom is negative, those are going to run the risk of immune attack from the mom. It's not always, but a decent amount of time. The mom will start making antibodies that cross the placenta, and then they're roaming around in the baby's body, and they're trying to attack the baby's blood cells. And when the baby is born, it will have liver problems because it has all of these complexes of mom's antibodies and the baby's blood cells, and that can be harmful for the baby. So it's called hemolytic disease of the newborn. Hemolytic because it's a blood attack. The mom's antibodies attack the baby's blood. So we don't want that to happen. And if it's known that the mom has a negative blood type, and this is her second pregnancy or subsequent, the mom can get shots toward the end of pregnancy to give her antibodies against her own antibodies. They're called anti-RH, or the shot is called Rogaine shots. So we give the mom Rogaine shots from the mom. And what those are antibodies to block her antibodies that would harm the baby. They're not blocking all of her antibodies, it's just the ones that would be harming the baby. It is called Rogaine or anti-RH. So if you're going into nursing, you'll see this again when you get to maternal fetal medicine. I never had to have these because I'm a positive blood type. That it's only certain women, if you're negative blood type, subsequent pregnancies, you would need this shot to help prevent this hemolytic disease of the newborn. And that's the only slide that your book has about type 2. There's a few other examples of type 2 that I just want to list down. So let's go back to this review chart. Type 2 can be called, I've got this wrong on here. I need to change this. Type 2 is called antibody mediated. Antibody mediated. So you've got antibodies floating around in your blood and attacking tissues as antibodies. Antibody mediated. So this has to do with blood group incompatibility. So if we do incorrect blood transfusions, that would cause this. If we have maternal fetal antigen mismatch, let's say, that would cause type 2 hypersensitivity. And there's a disease called myasthenia gravis, which is autoimmune throat paralysis. That one has a similar cause where you have antibodies floating around in the blood and they are attacking a particular cell in a person's body. Type 2. This says incorrect blood transfusion. Like if you try to give a O positive person AB negative blood, you shouldn't do that. This type of thing is going to happen. The maternal fetal blood type mismatch is an example of type 2 hypersensitivity, and this disease called myasthenia gravis is an example of that. Next we have type 3, and type 3 is the one that is formation of immune complexes. In this one, it's a little bit different than type 2. There's still antibodies involved, but we have antibodies clumping, binding, with antigens. And the key difference with a type 3 reaction is that those clumps get lodged in tissues, or they get stuck in body tissues. They get stuck, and then it's like, I don't know, it's like having we had a giant pile of trash suddenly in this room. And then all these people started coming in here to clean it up, and then we couldn't have class. They're disrupting the normal function of the tissue. So the clumps are then going to worsen inflammation in that area. This one would be very localized to a certain tissue, and it's not floating around through the body fluids, it's stuck in the tissue. If it happens in the skin, it can cause these type of responses, which to me as a not medically trained person, it's like, well, that was these kind of responses. Your training will not include, oh, can you diagnose this hypersensitivity based on the person's skin? That's a dermatology thing. You might learn to do some of that if you become a derm nurse. Most students say they don't want to do that after they rotate through those, but it can look like this. One place where this does tend to happen to people is if they have hypersensitivity that causes them arthritis, a certain type of arthritis. So specifically, you can have rheumatoid arthritis from this if the clumps are in your joints. So if they occur in joints, as a type 3 immune response, it's called rheumatoid arthritis. And that's an autoimmune disorder. Your joints won't bend very well because you've got this clumps of antibodies and antigen in there, and then you get inflammation. If it keeps going, you can get scarring in your joints, and they really get frozen. If the complexes are kind of going all throughout your entire body in unpredictable locations, that tends to happen in a disease called lupus. If you have people you know that have lupus, it's really hard for them because they kind of don't know when it's going to get bad and when it's going to get better. And you usually can't see anything wrong with them from the outside. And it can make them feel just awful for no apparent reason. So some people in their life would be like, there's really not anything wrong with you. It's a lot of symptoms and not so many signs. It's very hard. And it tends to happen more with women. This is the particular name specifically for lupus. So it's called systemic lupus erythematosus. And you can see that in the slides, but the abbreviation for it is SLE. Systemic lupus erythematosus. And this is also an autoimmune disorder. We don't know why it happens to people, why they start attacking their own body like this, but it's really difficult for people to suffer from this. Those are the two I want you to know for type 3. Those two specific examples. Lupus and rheumatoid arthritis. Then we have one more big division of the overreactions, of the hypersensitivities. And these are called type 4. And in type 4, this is different from all the rest because they are T-cell mediated. It's not antibodies floating around, and it is not immediate. It's a little bit delayed. It's not immune complexes from antibodies lodging in tissues. This one has a different cause. So in type 4, T cells are attacking human cells inappropriately. It's a cell attack, not an antibody attack. So this one would involve cytotoxic T cells that we learned about last week. They're supposed to kill cancerous cells, or they're supposed to kill virus-infected cells, but for some reason they are now killing normal innocent cells in the human body and causing bad side effects. Because these have to do with cells attacking cells, they are going to have a little bit of a time delay. So it's not going to be so quick as a true allergy. There's going to be a little bit of a time delay. So we can also refer to these as a delayed hypersensitivity. Like you're exposed to the thing, and then sometime later, not right away, but sometime later, you start having this inflammatory response. And there's two examples of this that I want you to know. More than two examples, but two that I want you to know. This one is a skin reaction that shows up a while after you touch something, and it's called contact dermatitis. Contact, because you touched it. Dermatitis. And this is an example of what it looks like. It looks like a skin response. The key to this is you have to ask the person, when did this show up? And what did you touch in the 3 days before it? So for most people, if you have a poison ivy response, it's classified as contact dermatitis, because it's not like you touch it and you're like, oh my gosh, it's, you know, later that night you go to take a shower and oh my gosh, I got in it. It shows up later. Or if you can't wear certain kind of earrings because your ears swell up, that's contact dermatitis of a metal. I have that. I can wear them for a while. Like I can wear them to an event, just not all day at work. Or sometimes I make it until 3. I gotta get those out. Starting to itch. That's contact dermatitis. So the difference between this and type 1 is the timing in diagnosing it. Did it show up right away, or did it show up 3 hours later or 2 days later? If it's not immediate, then we would classify it as a type 4 response. The other one that is a type 4 response that has a delayed reaction is if we reject a transplanted organ. Like that's a foreign object going into the body. And if it doesn't have a close enough match to us, our T cells will eventually figure out that it's foreign and they'll start attacking it and trying to kill it. And that's what happens when we say that someone is rejecting their organ transplant. That particular version we would call host, like our body is rejecting the organ that we just tried to put into us. So host versus graft is that specific type of organ rejection. Host versus graft. So that's when the organ recipient, their immune cells attack the donated organ. The host attacks the graft. That's the most common type of organ rejection. There's another type of graft rejection, technically, that's the opposite, where it's the graft versus the host. Graft versus host. May sound like, how could the graft attack you? The graft can attack you if the graft is immune cells. So this would happen during a bone marrow transplant, most likely. So in this one, the donor's immune cells like maybe because they donated bone marrow. Usually how this happens. Attack the new host. So if you know people that have to get a bone marrow transplant, we have to be so careful that we get the closest possible match, tissue match, so that when the person donates bone marrow that contains immune cells, that the immune cells don't go into the new person's body and start attacking them. That's the opposite of what we want. We're trying to give them immune cells to help them, but if you don't have enough sameness there, the new immune cells are going to attack the new person. That's called graft versus host disease. When we're giving people grafts, we can have different sources of where those come from and different names for those. The best way to have a graft is to graft to yourself. What? You ever heard of somebody getting a skin, they get burned and they need a skin graft, and so they take a big patch of skin off of their leg and they put it somewhere else? That would be called autograft. You donate tissue to your own self, and you're not going to reject that. So that would be helpful if possible, if you're able to autograft. Donate the tissue to yourself. The next best is isograft. If you could get a graft from your genetically identical twin, you're probably not going to reject it. We call that isograft. The next best is allograft. So you don't have, most of us don't have an identical twin. I think if I did, we would not get along. I would annoy myself. Any of you a twin? It's maybe the first year in a long time I haven't taught on twins. Anyway, allograft, you get a tissue donation from somebody else who's kind of matched to you. But they're not identical twin to you. So if you got one from your fraternal twin, or if you got one from your mom or your sister, that would be an allograft. And then there's one called xenograft. You get a tissue donation from another animal that's not even human. Xeno, like foreign. A long time ago, surgeons and cell biologists tried to do experiments to give people animal organs, and they almost always rejected them. But just last month, maybe it was, yeah, this is a new month. Last month, you may have seen that there were some exciting news about pig kidneys. Like they took a pig kidney that was genetically engineered a certain way, and they hooked it up to a brain dead person who needed a kidney for a few days, and it worked. So xenografts might be more of a thing in the next few years, in a way to get organs when we don't have enough human organ donors. This picture is out of order. This is rheumatoid arthritis, and this is lupus. Some people that have lupus will have a red patches on their face, kind of in a butterfly shape. Not always, but sometimes. These are examples of type 3 hypersensitivity. So looking back at this review chart, you need to know the numbers and their specific names and a couple of examples of each type. This will be multiple choice type of stuff on the Monday exam. This is, I wouldn't study this as much, but numbers, names, examples. What I want to spend the last 8 minutes on, or whatever we've got, is autoimmune diseases. I kind of mentioned them, but not so much said exactly what they are. Autoimmune diseases. So auto is coming from self-immune diseases. And what is happening during these, and there's a whole range of them, is that the person's immune system is attacking their own tissues. It's not because of a tissue graft, it's not a mom to baby thing, it's not an allergen coming to us from outside the body. It's our immune system attacking our own body. Autoimmune. So we're attacking our own body and specifically our own self-antigens. We destroy a part of ourself. That's what they are. These are more common in women for some reason. They are more common in first world countries. They are more common in the past 50 years. Let's say the past 30 years. And they are a cause of pretty intense suffering for lots of people. There's a lot of research going on to figure out why do women have them more, and why do first world countries have them more, and why are they more common lately? But there's not really good answers for that. One of the leading theories for how these get caused is it might be something going wrong with immune systems in children. So it's possible that children's immune systems aren't getting trained properly during their youth. Because when we're young, our immune system is supposed to learn what's part of me, and I should leave that alone and not attack it, versus what's not part of me. Yeah, McKinley.
Do you think it could possibly be that, like, since a first world country is more sanitary than, say, a third world country, that our immune systems, like, don't really have anything to do, so when they come across something that's remotely, I guess, then they would attack?
Yeah, that's also a theory about all of the different hypersensitivities. Like, because we're not exposed to enough dirt and microbes and stuff when we're a child, that our immune system doesn't form properly because our parents didn't let us get dirty enough, or
Yeah,
that is a big theory also.
like in third world countries, they deal with like their immune systems too. So I feel like
Yeah, well, a way you could explain it is in countries less concerned with sanitation, right? Like those kids' immune system get exposed to a lot, and they get a more diverse immune education than if you grow up where someone vacuums every day and they don't let you crawl in the dirt. You know, that is a big theory as well about why autoimmune diseases are so much worse in first world countries and why they're worse recently. So I don't know, as soon as I heard about that, I'm like, well, okay, good. You don't need to clean as much. Maybe you should put that in your mouth. Just go on. And then like as you have more kids, it's just kind of like guess which, this is anecdotal, but guess which kid has the most allergies? Noah, the most serious ones. Moses in the middle, who like got the least attention because we just had another baby, like right after it. Moses always like gets the short end of everything. He's not allergic to anything. Joseph's allergic to a lot of stuff. I don't want to rush the rest of autoimmune disease, so just knowing what they are, we'll have on the first test, maybe in the multiple choice. But we're going to start here after the test and finish this because there's so many kinds of autoimmune diseases, and I want you to know at least a little bit about these major ones plus a few more. So that's the cutoff between what's exam 4. No, don't study this one for this test. Just leave it for exam 5. Wow, I just said exam 5. We're moving on this semester.
That table 14.2.
Let's see.
why thank you.
Yeah.